My name is Ranu Jang. As I'm Associate Vice Chancellor and Executive Director of the Institute for Integrative and Innovative Research, IQDAR. Most of you here know who I am. Sometimes we have people on Zoom who don't know what Institute is all about. So the Institute, as you have seen earlier, pioneering solutions to wicked problems. We are driven by purpose, and there are 5 words that kind of define what we do: the integrative work, innovation, but really about convergence of research as we try to deploy solutions so that we can make societal impact. And that is our purpose with which we work with. And the other thing is, when we talk about convergence, we're not just talking about convergence of disciplines, but talking about convergence across sectors. So multiple sectors coming together and thereby helping deploy the solutions. So clearly, we want to be for the leaders in this space, as we should, So we are delighted that in the speaker series, we are able to bring in speakers who bring in multiple perspectives and actually reflect that aspiration, that vision of bringing convergence to the solutions together. And so today we have got a distinguished panel of speakers from our very own Walton College of Business. And if you have not seen all the accolades of the rankings and all of that came out recently, then you should look those up, because we are very, very proud of our business college and what it is doing, and especially given our region, it has played a outsized role in our own economy itself, the economic impact of it. But we have 3 speakers with us. We had Dr. David Dobrzynkowski. I hope I got it right. He's the Delhi and Transport Department of Supply Chain Management. So you will see how it all ties up. But when you hear the titles of the things, you think, what supply chain got to do with it? Can't deploy anything without supply chain. That's one of the things. And so he looks very specifically in terms of healthcare and humanitarian aspects and sharing the economic context of all of that. So that's one aspect about, being able to deploy things. And then, you are, I think, editor of a journal of operations management and decision management. So the things that have been happening there, but he's also been, we said that, the Walton School is well known on Bloomberg, on NPR, and, we called him to give input like that. And then we have Dr. Shannon Younger, and her research is in entrepreneurship and organizational theory. So obviously you can't have any supply chain if you don't have entrepreneurs. So ties in right there, right? And then you are exploring how new ventures become and remain meaningful in the markets when they compete. Again, another different aspect coming in to tie the whole thing together. And you bring in the undergraduate students into the party. And so undergraduate students and the experience for them. And then we have got Jay Grandy, who rounds out our panel. And his research focused on entrepreneurship, non-market strategies, on corporate social responsibility. So I love it when I think about all of the things you're talking about, right? We said our purpose was societal impact. Social responsibility comes there. Deployment, the supply chain part of it. Innovation and entrepreneurship, Shannon, yours. So we're all really super excited to have you all here. We look forward to hearing things from you today, but our hope is that this is going to really basically sprout a much bigger, longer, engagement within IQDAR's different facets and what you all are doing. We have health as part of our efforts. We have food as part of our efforts, and merging those together, including and also thinking about safety and security of all of the things that underlie the food and the ecosystem. So in this context, let me welcome you all. And I think you are going to do a 2-part Cooper, right? So Jake and Shannon, please welcome. You got it.
Okay, so I'm Jay Grandy, here to present my research with Shannon Younger on market category stagnation and regulated markets, where we look at the market for birth centers. The genesis of this project is my wife is a midwife. She works in a birth center, and given that a lot of my research really focuses on entrepreneurship in regulated markets, how do entrepreneurs navigate complicated regulatory environments, how those environments influence entrepreneurial decision making. I looked at her experience in a birth center. I thought this is probably the most complicated market, regulated market I've ever seen. And so, of course, I wanted to study it. Shannon also has some personal experience. We'll share now or later. Okay. With birth centers as well. So it's a good partnership. We both have a personal connection to the topic and also, of course, our research interests. All right. So birth centers. A birth center is any health facility, place, institution, not a hospital or in a hospital, where births are planned to occur away from the mother's residence following normal and complicated pregnancy. Perhaps due to the popularity of the growing popularity of birth centers, a lot of hospitals have started creating facilities they call birth centers. These are distinct. These are freestanding birth centers that we're studying. The hospital birth centers tend to be called different names, sometimes alongside midwifery units, which are attached to the hospital and usually next to the labor and delivery unit and staffed with midwives typically, but also doctors. Okay. All right, so why do we need birth centers, or why do we want birth centers? Well, from the mother's perspective, or the family's perspective, birth centers offer a more personalized, less interventionalist birthing experience. Often it's a very home-like setting, not a white sterile hospital room. Often has like a birthing tub, things like you don't typically see in the labor and delivery unit. It offers continuous care, typically from a midwife, as opposed to what might be a more typical hospital labor and delivery unit experience, where you see the doctor a few times and then he catches the baby. The midwife's much more present with the mother, but also prenatal, postnatal care, also more continuous. Birth centers offer a lot more freedom of movement during the birth experience, right? And the opportunity for different labor positions. Again, in contrast to a typical hospital setting where it's your hospital bed, the mother's on her back. Different positions, the tub, the bed, whatever. And again, it's more home-like and family-centered approach. So the families are actually encouraged to participate and be involved in the birth experience if that's what they want. So those are the personal reasons. There's also some health and economic reasons why we might want to have birth centers. Birth centers offer lower rates of cesarean and other medical interventions. Again, this is all else being equal. Birth centers are only for low-risk births, but when you compare low-risk birth in a birth center to a low-risk birth in a hospital setting, this is how they differ. So lower rates of cesarean, lower medical interventions. You see lower rates of preterm birth and lower incidence of lower birth weight. Again, this might be because of the model of care, where midwives spend a lot more time with education of the mother. Birth centers also have higher after birth, high rates of breastfeeding, right, and longer duration of breastfeeding. There are reduced disparities in outcomes based on race and social class in birth centers, right? So this is a problem in the United States where minority populations tend to have worse birth outcomes in a hospital setting. That disparity tends to disappear at a birth center. And economically, there's an NIH study that looks at this. Birth centers, because they have less intervention, because they're staffed with midwives, not doctors, midwives are cheaper to employ. And doctors, they tend to save a lot of money. Oh, thank you. Yeah, so they found that a shift of 1% of the births in the United States to birth centers would result in $187 million in system-wide savings. There's another statistic I didn't put up here, but it's like $4 billion over the next 10 years or something like that in savings if you shifted to 1%. Right. All right, so that's what birth centers are. The main protagonists here of birth centers are midwives. Of course, anybody can found a birth center. I mean, you or I could start a birth center if we wanted. That typically doesn't happen. In our research, we found cases where chiropractors have started birth centers. They're not catching the babies, but they're the ones who found them. But typically, it's a midwife that founds a birth center. Okay, and midwives come in two flavors. There's the certified nurse midwife, and there's the licensed midwife. There's some variation across states in how they're defined, but this is pretty typical. Certified nurse midwives are they're nurses. First, they become registered nurses, and then they get a master's degree, or more recently, they get DNPs, Doctor of Nursing Practice, in women's health and midwifery. Licensed midwives, in contrast, typically don't enter the profession with any formal education. They enter into an apprenticeship model with another midwife who's been practicing, another licensed midwife who's been practicing, and they train for several years, accumulate a certain number of births under their belt, and take a licensing exam, and then they become their own licensed midwife. Okay. Some of this information is specific to our context. Our focal case here is California. So in California, certified nurse midwives are overseen by the board of nurse examiners, and licensed midwives are overseen by the board of medical examiners. It's not true across all states, different boards, sometimes the same board, but for us, this is the difference. And this next point is true across the US. Nurse midwives, the first choice of practice is typically in a hospital setting, right? So you will find more nurse midwives in hospitals than not in hospitals. Licensed midwives do not practice in hospitals. They do birth center births or home births. That's not to say nurse midwives don't do birth centers or home births. They can do that as well. It's just less typical. And again, California specific, nurse midwives were required to have physician supervision, not in the room with them at all times, but some physician who agreed to supervise the midwife's care and decisions. That was required in California until 2021. And for the licensed midwives in California, they did not require supervision since 1999. So very different there. Shannon will get into more details about why those differences are important. So to get to the research question here, we're really interested in stagnation versus growth. So a lot of prior work has talked about how new market categories will emerge and how those categories will thrive, right? How did we come up with satellite radio or Uber, Airbnb, these types of things? What allowed them to emerge, and what allowed them to totally thrive? Some cases completely dominate markets. There's a lot less research, but there is some research on what causes them to decline and perish, right? Why will some markets disappear? What we wanted to know is what causes a market to emerge with all the promise of growing and thriving, but fail to do so, right? It'll neither flourish nor fail. So our research setting, as I mentioned, we're focused on California. This is a qualitative study, comparative case study. We focus on California, but Washington State is our counterfactual. Both of these states are part of this initial wave of 6 states that started birth centers around the same era. We chose these 2 in particular because they're both on the West Coast. They share similar culture. They developed in parallel along similar timelines. Also, when we were interviewing founders, they constantly referred to each other's state, right? And so it's top of their mind as well that this is a counterfactual state for each other. The study period we're looking at here is 1951 to 2021. And the key difference here in these states is regulatory, right? As you gather from the title, we're looking at regulatory ambiguity. California is the state that has really high regulatory ambiguity. Washington State, in contrast, has very streamlined, clear regulatory process for founding a birth center, for getting a license to found a birth center. Just to give you a little bit of data, it's a qualitative study, but we have some quantitative information here to show you. If you look at births in a birth center, the number of births in a birth center by state, California being in the blue, Washington being in orange, you can see they track pretty much, right? They're the same. It doesn't sound like Washington would be a very good counterfactual until you look at by population. Like California is about 10 times the population of Washington State. So if you look at the number of births per million inhabitants, then you can see that Washington State has much more, many more births in birth centers. Oops. You get a similar curve here with birth centers. The number of births that occur in a birth center in each state, they track pretty close to each other over time. But when you scale it to population, you see Washington like significantly outstrip California in terms of number of birth centers. California should have probably over 10 times as many birth centers to track with Washington. So we see this as evidence that there's probably some latent demand in California, given that the states are very similar, for more birth centers. But what's stopping this market has already emerged? Birth centers exist, but what's stopping it from thriving, tracking the birth of Washington state? Okay. And so Shannon's going to take off here with how and why these differences occur.
Thanks. Both of my kiddos were born with midwives. And so when Jake came to me and said, I have this idea, it seemed particularly intriguing and also one of those projects that is personal as well, right? Which is so fun about this job. So the question becomes, how did this happen? How did we get to this point where this market has stagnated so dramatically, especially in comparison to another state that seems to be thriving? Why did this occur? And I think we've uncovered a few things from this. We looked at historical newspaper articles as well as extensive interviews with current regulators, midwives, birth center founders in both states, both Washington and California. And one of the biggest, most significant factors that we have identified is that of regulatory ambiguity. There are a few aspects of this that I think are important to note. One is that it refers to this uncertainty or inexactness of policy by a governing body, right, around a particular action or industry. And that is certainly occurring in this space, as we will show you. Additionally, that regulatory ambiguity obfuscates relationships so that the relationship between the firms and the regulators becomes more complex, more confusing, more difficult to navigate. We're also seeing that here in this state. One of the most significant things that we found within that regulatory ambiguity that contributed to the regulatory ambiguity is this notion of implementation confusion. How are midwives or these birth center founders supposed to actually implement the regulations around birth centers? It was incredibly difficult for those in California to disentangle what they're supposed to do with the regulation. And we see that in a few different ways. One is there were significant regulatory lapses. So here's an example from a law review talking about what's happening within the regulation. In 1949, midwifery was effectively eliminated in California by the removal of the authority of the Board of Medical Examiners to issue a certificate to practice midwifery. Also repealed in the same year were the sections of the Business and Professions Code, which prescribe the standards and educational requirements for obtaining a midwifery certificate. But left in the code was the definitional section which defined what a midwife could do with his or her certificate. However, there was absolutely no way to obtain a valid certificate. So you can have a certificate, but you just can't get one, right? This is a great example of how there were significant regulatory lapses where these midwives just fell between the cracks. And that then had significant implications for birth centers down the line. Additionally, we saw task redundancy left, right, and center, where there was no real clear model for how to navigate the regulation. And so it meant that midwives had to explain what they did and make their case to all sorts of different governing bodies. That might be a municipal building inspector, that might be a county inspector, that might be state inspectors, that might be licensees from those that oversee the midwives to those that oversee the birth centers nationally, right? There are all sorts of different governing bodies that they had to report to. And as a result, then, because there was no real clear blueprint, it resulted in a lot of task redundancy. Additionally, there were endless regulatory loops. And here's an example. In order to be a licensed birth center, you have to be a provider of a medical program called CPSP, Comprehensive Perinatal Services Program. So you have to be a CPSP provider in order to apply for a license for your birth center. In order to be a CPSP provider, you have to be a Medi-Cal provider, which is the California version of Medicaid. But in order to be credentialed as a Medi-Cal provider, you have to be a licensed birth center. So if you have to be a licensed birth center in order to be a Medi-Cal, but you have to be Medi-Cal in order to get the license, How do you do that if one is reliant on the other? Right? You can see significant issues with this endless regulatory loop where the midwives are left thinking, how am I supposed to navigate this? Right? Of course, that's going to obfuscate the relationship between the firm and the regulator, and also obfuscate the relationship between firm entrepreneurs, people who want to be entrepreneurs, and the overall market itself. We also saw a lot of jurisdictional redundancy. And let me show you one example of this through fragmented power structures. There was all sort of motley oversight as well, where you're overseen by some people for this thing and some people for that thing. And also that there was optional regulation in California. One of the clear defining features of this was that as birth centers, you could choose in to being licensed. It was optional, but you did not have to. Whereas in Washington, you are obligated to. And that also led to then fracturing within the industry itself and prevented growth. But this fragmented power structures is pretty complex. This is just a microcosm of what is happening within power as it relates to birth centers. So if we think of birth centers here and all of these arrows as the direction that power flows, we see that midwives, we have two different types of midwives, and they are each kind of influenced, but their governing bodies are different. Not to mention, you have insurance companies that sometimes have direct relationship to these birth centers, but also have indirect relationship via hospital, physician, maybe physician groups. And then you have a number of different governmental agencies as well that may have direct or indirect power over these birth centers. So as you can see, when I talk about that notion of motley oversight, this is like, gosh, this is so clear, right? And so the argument that we are making in this paper is that these fragmented power structures are one way in which there was jurisdictional redundancy that led to regulatory ambiguity. Ultimately, the question becomes, okay, so what can entrepreneurs do, right? We are really interested not just in the policy implications, but also in what entrepreneurs, what firms can do to help work within and maybe even around some of these regulatory structures. I would argue that there are kind of three things that they can do. One is what we found in Washington was that these midwives really adopted a united front. They said, we are going to band together. Even if I'm a CNM and you're an LM, we are going to work together because we are working toward a greater good, a common good. And so they really banded together to increase education for all of the different individuals and entities in that power structure. They worked together to develop evidence-based information about the efficacy of their work. They really lobbied together and created additional streamlined policy work. So those relationships and that unified front was very significant for these midwives in Washington. Additionally, they really worked hard to professionalize their work. So here they are working together through licensure, through certification, making sure that what works for one midwife also works for another, so that they can create some blueprints around what it looks like to navigate through this regulatory structure, right? It's when there is no blueprint, it really creates that task redundancy for those midwives who don't know, well, what did you do? And will it work for me, right? And so we found in Washington that they really worked together in that united front matter together as they worked to professionalize their own industry. And then finally, this notion of really mining your individual networks. We know, as the research suggests, that networks can be incredibly beneficial to us, right? We're here today because we know David. David knows a lot more people than an assistant professor in a business school in my department. So thank you, David. But we can find with those midwives that they can really mine their individual networks, and they can do so in a number of different ways. One is, maybe they know a doctor and they can make that case to that doctor who maybe has a little bit more power and can start to work on some cross collaboration. They can also really focus on reputation management, improving the reputation of midwives, that they are no longer just doing these one-off births in homes in the middle of the country, and in rural areas, but they really are educated well, they are effective, they know the limits and boundaries of their work, and they really have care and concern for the, their patient population. So really using those individual networks to improve collaboration and also improve their own reputations. Those were some significant findings from the interviews that we did in Washington about what these entrepreneurs can do. Overall, I want to leave a few key takeaways. Obviously, there are significant policy implications for how regulation can be improved. And this is probably just one microcosm of that. But in this area in particular, there are successful models for what it looks like to minimize barriers for entry. And we see that in Washington, the minimization of those barriers, providing a clear website that says, here are the steps that you need to take to get licensed as a birth center. That's a really simple way that a state can implement more structure and more of a model based on what another state is doing to improve and increase, hopefully, entrepreneurial entry. Additionally, it's not like we have to reinvent the wheel. We can use these other models that do exist. Moreover, entrepreneurs, they can certainly use their networks, and sometimes that can come with a little bit of an icky feeling, like I don't want to just, pull on these people and ask them to do something. But really, networks are there for these purposes to help increase your ability to do something. And we can certainly encourage entrepreneurs to do that. And then finally, for these professional associations like the midwives, even though there are multiple different types of midwives, collaboration really does indeed work best. And they can really see the most gains when they are working together as unified firms. Thank you so much.
Awesome. Well, thanks, Shannon. Awesome. Well, thanks, Shannon. Really appreciate that, Shannon and Jake. So I'm David Dobrikowski. I have the pleasure of serving as director of Walton College's Healthcare Business Initiatives. And as we get started here with my little portion of the talk, I just want to thank Jake and Shannon for not only doing some really awesome, cool research, but bringing it here because it highlights some of the work that we're doing at the Walton College at the intersection of policy, healthcare, and creating improved access to care and so forth. Here at the Walton College, Jake and Shannon are two, and I'm, I guess, three of what is about, between 15 and 20 faculty who are working in some way, shape, or form to improve the delivery of healthcare, the financing of healthcare, and access to care, which I know is a wicked problem that IQBAR cares a lot about. So I want to thank Dr. Jung, I want to thank Meredith, I want to thank Dahlia for inviting us to be with you all today. So Dr. Jung started out with a great kind of question, right? I appreciated that introduction when she asked, what in the world, does business and supply chain have to do with healthcare, and how can we work more closely and collaboratively together? In the little bit that I know about the organization, I know that solving wicked problems requires this type of integrated collaborative approach, and access to care, particularly here in the state of Arkansas, particularly when it comes to maternal fetal care, is a really wicked, thorny problem. So I thought it was really relevant to bring you folks in, and thanks so much for the great work that you're doing. But what in the world does that have to do with policy and supply chain? Well, I'm glad you asked. So what do we do? So if you just think, and I'm going to kind of breeze through this stuff quickly, but because like any good professor, I brought a golf bag full of clubs, and I'm only going to hit about 2 of them. Okay. So in any way, if you think about healthcare historically, right, what would happen is we would wait until a healthcare event happened. Somebody got sick, a patient got sick, and at that point, we would focus on treating the patient, right? But prevention historically really wasn't a very important focus for us. We talk about it, we hand wave at it, we provide lip service, but we didn't historically place much emphasis on it, right? Because there's frankly very little incentive to do so. Our payment methods back from the 1940s and 50s when CMS was created was focused on what's called a cost plus model, believe it or not, right? Where hospitals and providers were paid their cost plus a reasonable margin. So it's no surprise that it became a very supply side oriented marketplace. And by the way, before my wacky PhD, I worked in healthcare administration for 13 years, running MRI centers, outpatient diagnostic imaging facilities, as well as working in acute care. So these things really hit home to me. But there have been reforms, like what we call value-based purchasing, that's still on the prevention side. If you've been an inpatient at Mercy or Washington Regional, you've gotten a phone call within the next week that asks you about your visit, right, or your inpatient hospital stay. Well, that's CMS outsourcing to a survey company that's collecting what we call HCAHPS scores. And those HCAHPS scores measure your satisfaction. They measure how your physician or nurse communicated with you, how responsive they were to the patients. And those HCAHPS scores under this value-based purchasing program that was started around 8 or 9 years ago actually index the hospital's payments up and down now. So by 2%, which may not sound like much, but the average hospital operating margin today is between 1% and 3%. So if CMS, the Centers for Medicare and Medicaid Services, represent half of your patient population, that's a pretty important number. This is starting to try to improve quality and the way that we treat patients in the hospital. But we really know that we need to be a little bit more focused on preventive care. So also during the last probably 20 years, we've seen developments happen to try to provide more incentive to providers to care about the prevention of that claim or that event in the first place. Reforms like consumer-directed health plans under the George W. Bush administration, health savings account, then patient-centered medical homes and accountable care organizations have led to an environment where hospitals and health systems are much more concerned about population health, or keeping the population that they serve in a given community or what we call catchment area healthy. Then boom, what happened? Well, COVID happened, right? About 5 years ago. And we started to see that, wow, folks with fewer comorbidities tended to fare better. So this provided now patients with more incentive. You might think, well, we have incentive, we want to be healthy, but the reality is, you know, as consumers, we put much more thought into a big screen TV that we buy than we do oftentimes managing our healthcare. But you know, COVID did bring to light, as bad as it was, and as many negative, you know, attributes that it manifested with COVID, it did bring to light the fact that folks with fewer comorbidities tend to do better. Around this time, COVID also really accelerated the use of telemedicine as a means to provide treatment, if you will, to patients and provide a whole new platform, which is what supply chain people are really interested in. What are the delivery platforms and mechanisms that we use to deliver the right product to the right customer at the right place in the right time? That's really what supply chain is all about. So this is kind of the link. So around this time also, of course, especially in this region with the work of Alice Walton, integrative medicine became a much bigger deal, trying to treat the whole person instead of just providing treatment. Patient engagement is more important than ever, playing a more active role in our healthcare, and these methods and mechanisms kind of help to promote that. So today we're in a whole new world where patients and providers, and also non-traditional healthcare providers of like vitamins, minerals, and supplements, exercise and health, at-home diagnostics, whether it be nasal swabs or even blood tests, over-the-counter therapeutics and so forth, are a big deal to try to keep patients, not just healthy, but also allow them to treat themselves, like through at-home diagnostics. This is leading to more provider to consumer or provider to patient types of interactions that are outside of the walls of the hospital or outside of the walls of a clinic, which is making supply chain a heck of a lot more complicated because there's more volume and variety of procedures. Which is actually placing pressure on last mile delivery, using sharing economy and gig drivers, drones and smart mobility to deliver the tools that we need at home to make ourselves healthy and more engaged. Here in Northwest Arkansas, we're very blessed. We get drone delivery, right? And if I had more time, I'd show you a video of my 8 and 10-year-old opening up a drone delivery of a bunch of bananas and some Miralax. I don't know who that was for, but anyway. And all at the same time, we're trying to do this while being more resilient. So this resiliency thing, and from a supply chain perspective, many health systems are creating what we call consolidated service centers. They're getting much more involved in managing their supply chain So all of a sudden, these issues are becoming very important from a supply chain perspective. So today we're going to talk about telemedicine specifically for the next probably 8 minutes or so. And we'll start to show the link between how telemedicine will bring together these whole ideas of supply chain in terms of providing the platform, hopefully improving access to care, which is an issue that IQDAR is interested in, and how policy kind of drives this. So I mentioned HCAPS. I mentioned how providers are now incentivized to provide higher levels of quality care to us, both experientially in terms of the experience that we have, as well as from a clinical quality perspective, because it indexes their payments up and down. Well, one of the most important and telling metrics for a provider is what's called left without being seen or leave without being seen. Did the patient stay to access care, or did they end up leaving? This is a key operational metric that we care about as operations and supply chain scholars, because it tells us a lot about the quality that the healthcare providers provide, the timeliness of care, and so forth and so on. Look at this poor fellow. How long shall we put down that this fellow had to wait? 3 hours and 58 minutes. So we know that leaving with, can't blame the guy for leaving if he would have left, right? Maybe he should have left. I don't know. Well, I mean, ultimately, I think in this cartoon he didn't. But anyway, we know clearly that it's a cartoon, and I'm not trying to be crass, okay? But anyway, we know clearly that leaving without being seen has health consequences for patients, whether it be chronic conditions like diabetes management, so forth, or whether it be acute care type of settings like in the emergency department. Okay, so from a provider's perspective, they care about patients leaving without being seen because missed appointments account for $150,000 annually for just a single practitioner, right? So it's costly. The total cost of no-shows estimated in the United States healthcare system is about $150 billion a year. We do know that about a third of patients leave without being seen because of long wait times. And wait times is a big deal in operations. Like we spend a lot of time, like there are people that have built their whole career on just trying to improve wait times. And 20% of patients say they've switched physicians simply because of long wait times. So for providers, wait times are important. To patients, we care because, we've all experienced this, right? Your appointment with the doctor is at 11:15, but fortunately, or unfortunately for you, his appointment with you isn't until 12:15, right? So we've all kind of been there, and we felt as a result of it, I think frustration, right? A lot of times we get frustrated. So because of this, long wait times have also been linked to our frustration. And as you'll see, when we get frustrated, patients are dissatisfied and tend to leave without being seen, right? So from an operational platform perspective, just trust me, telemedicine is growing, has grown dramatically as a result of the pandemic because providers could finally get paid for it. In healthcare, right, programs, technologies follow payment streams, okay? Look at electronic medical records, right? The most unfortunate friend I had was an entrepreneur who owned an electronic medical health record company in 1998. Poor guy had no customers, right? Because patients weren't going to pay for it, insurance companies weren't going to pay for it, and I used to work for United Healthcare, so I'm not slamming insurance companies, but insurance companies weren't going to pay for it, providers weren't going to pay for it because, heck, there's nothing wrong with the paper chart I've got. So there was no customer for it, right? Until the HITECH Act about 10 years ago started to incentivize providers to implement electronic medical records. Well, COVID did the same thing for telemedicine. And so now it's, almost a $500 billion industry. 83% of patients say they'll continue to use telemedicine after the pandemic. And no surprise, because the average telemedicine appointment wait time is about 20 minutes compared to going to your physician, which compared to about an hour and 21 minute in-person visit, right? So our research questions for this study were to try to understand. This actually came from personal experience too, not as cool as having children with a midwife, but honest to goodness, I was sick about 2 years ago, had a cold or something. So I scheduled a telemedicine appointment with my physician, like 4 o'clock or 4:15. And I was waiting, and I was waiting, and I was waiting, and I was waiting, and I was waiting. And my wife picked up the boys from school and went over to Big Whiskey up in Rogers. And I thought, you know what? I'm not going to sit here by myself while my family enjoys a dinner. This is not a serious ailment. I'm going to Big Whiskey and have dinner with my family. So I got on my cell phone, right, and I waited for the doctor, my primary care physician, to come on. And finally, he came on about 55 minutes late, and I just stepped out of the restaurant and I had my telemedicine appointment. So it made me wonder, well, I wonder if patients react differently to wait times in telemedicine than they do if they're in an office, right? So, not just the literature, not just industry practice, but personal experience kind of led into this. So does the operational platform, telemedicine versus inpatient, like not inpatient, versus a face-to-face clinic visit, does this operational platform affect or moderate the relationship between a patient's wait time and the level of frustration they realize? And then also, how does that platform affect how that frustration influences a patient's proclivity to leave without being seen? I'm not going to bore you all, but if you look at the literature, there's been a ton done on wait times, but almost all of it is in the emergency department setting. And it doesn't look at patient's emotional state, and it hasn't looked yet at telemedicine. So we do that, right? One of the best tables that you'll ever put in a paper, right? One where the only check marks are your paper, right? Okay, so from a theoretical perspective, one thing that's really important for business that separates it from other disciplines is that where other disciplines are very concerned about the boxes or the variables, X goes up, Y goes up, X goes down, Y goes down, or up, right? Boxes are important to us, how we define variables are important to us, but they're not as important as the arrow. Okay, the arrow or the explanation of why X affects Y and under what conditions X might affect Y is really super important to us because we try to give business leaders insights into how they should be thinking about and making decisions as opposed to producing, you know, a product per se, right? We don't build apps. We don't provide, you know, new technology solutions. We provide insights that help those to be implemented, hopefully more effectively. So with that in mind, the theory that we're using here is what's called really self-determination theory that says we have basic psychological needs as human beings, the needs for autonomy, competence, and relatedness. And when we frustrate those needs, we become frustrated in those three categories, right? But good news, like I tell my 8-year-old, my 10-year-old, right? And sometimes other people I live with, certainly not my wife. We are not squirrels, right? We can control our behavior, right? We may not control how we get frustrated, but we can control how we react to that frustration, right? In other words, we can control our emotions, decisions, and actions, ultimately control whether or not we leave without being seen. Unfortunately, and this varies, right? We have a finite cognitive capability to control those emotions, right? And frustration or fatigue will diminish that competency that we have. And when we reach a threshold, we're no longer able to control ourselves, and we look like this fella. Okay. Now, so telemedicine is kind of a useful context to study because we know that patients perceive they have better access to care, they perceive they're going to have lower wait times, and they actually perceive it's going to be more convenient. That all sets an expectation for a patient that's going to influence how we react psychologically to our wait times. So this is what we did. We're using what's called a scenario-based experiment where we manipulate the wait time and we manipulate the platform, and we see how patients react from a frustration perspective to longer waits. Okay? And of course, then how it influences their leaving without being seen. We had 224 participants in our study, and this is actually really cool. So we partnered with a local healthcare provider, and we had actors follow a script in 2 different settings. One where a medical assistant greeted the patient, and then the patient, so this is in an office setting. The patients would either see the physician immediately then, and the physician would read a script, or, you know, the treatment group had a 10-minute wait. So they literally would sit there and wait for 10 minutes. And of course, we then replicated a telemedicine visit as well. Same type of thing. Mary, our MA, would greet the patient with the same script. The physician, Dr. Smith, would then come in either immediately or after Mary or after a 10-minute wait. So literally, if you're on this telemedicine thing, you're watching this thing spin. We had a little manipulated spinning thing, pretty neat. So, you know, our independent variable, of course, was the wait time. I'm going to kind of blow through some of this stuff and get right to the cool results. We had great manipulation checks and attention checks and everything statistically out in terms of, the strength of the manipulation to the psychometric properties of the variables that we're collecting. Because what we do then is we have patients or people, subjects, complete a survey after they experience the experiment. And here's what we found. So this is the relationship between telemedicine, wait times, and frustration. So what you see is kind of interesting, right? So when you are attending an in-office appointment, you start out a little bit less comfortable, a little bit more frustrated than if you're on a telemedicine type of appointment. But boy, look at the slope of that green line, the telemedicine, right? My tolerance of that wait time is much, much less than if I'm in an office, right? So we'll talk about the implications in just a minute. We also see that this interaction between the platform and the wait time is mediated by the frustrated feelings that we have. So in other words, if we can attack the frustration, we can do a much better job of improving that left without being seen. If you look at the direct effect of wait time on left without being seen by platform, you see something very similar, except obviously everything shifts to the left. So we start to lose that self-control much, much faster in our telemedicine type of environment. Okay. We check some other dependent variables like patient satisfaction and also copay to see if patients, would be financially sensitive to these. And we had similar results. Basically, patients are willing to pay less as they wait more, and that is amplified in a telemedicine environment. So there are insurance implications here for Blue Cross Blue Shield, our partners. There are certainly provider implications because remember, certainly we don't want our patients to leave without being seen. One of those studies showed that I think 14% of patients that leave without being, 20% of patients who left without being seen would return to a hospital in 14 days for care. And as you know, providers don't get paid for readmissions, 30-day readmissions anymore. So it's a big problem. Theoretically, we're making, I think, some important contributions to self-determination and self-control theory here, starting to understand how those wait times reduce my autonomy as a patient. I don't feel like I'm feeling constrained in terms of what I'm able to do with my healthcare. Certainly the competence, which makes a ton of sense because I'm at a physician office because I need that advice, so I'm feeling less confident as I wait longer. And of course, relatedness makes a lot of sense. I don't think anybody likes to wait because it's not a great way to build friends, influence people. From a managerial perspective, if you think about back in 1980, I worked for the Mercy out of Cincinnati, and I used one of my initial positions was as an internal consultant to help physicians take the frosted glass off their windows, get rid of the sliding window altogether, make sure the magazines are current, make sure the fish tank isn't dirty, put something pleasant on the TV. All elements of what we call the service-scape, which is the environment within which a service is provided, so that patients dealt better with wait times and they didn't do things like get dissatisfied and leave without being seen. Well, guess what? We need to start thinking about doing the same things in a telemedicine appointment. Figure out what we can do to get rid of that little turning dial, right? Maybe you can also, from a managerial perspective, set better expectations for patients so that they get less frustrated. From a regulatory perspective, maybe we need to start to think about how we can incentivize providers for reducing reneging behaviors from patients. In other words, if we're going to incentivize them for quality, if we're going to incentivize them for patient experience and satisfaction, maybe we should also start to track the percentage of patients that leave without being seen. So anyway, those are some thoughts. We've got maybe 7 minutes left. I want to thank you all. I think this is a nice compliment to my entrepreneurship colleagues. Did a nice job talking about how policy is important for improving access to care. And then as we look at one platform like telemedicine that improves access to care, looking at how to try to really improve the patient's experience using that telemedicine platform. So thank you.
Repeat the question then.
Okay.
When you analyze your data, did you look into how, for example, the age groups or familiarity with the technology plays a role with the frustration?
Yeah, thank you for that. So the question was, did we look at demographics like age, groups or telemedicine, or excuse me, technology familiarity. We did control for both of those. I didn't mention it. I apologize for that. But yeah, we did have both of those as controls. I don't recall if those were significant or not. I'm happy to look into it more carefully and talk to you offline about that. We also had screening questions. So all the subjects in the experiment opined that they had participated in a telemedicine appointment, I believe within the last year, maybe in the last 3 years, as well as a face-to-face physician appointment within the last either year or 3 years. Yeah. Yep, sure.
I have a silly suggestion and a serious question. It would seem to me that you'd improve patient satisfaction if one of 50 people waiting to be seen might offer a suggestion that those who are on the wait line can talk to each other while they're waiting. That's still a suggestion, but it might help.
So the comment was maybe we should have, when the patients form a queue, we should have them communicate with one another, let them communicate with one another. It might make people happier. That's actually an important part of the social, what they call the social service scape. There's a whole emerging line of research in how customers interact with one another to affect their service experience, whether it be at a Walmart retailer or whether it be in a physician office. Great point.
Yeah, sometimes in a waiting room, people start to talk to each other as well. But anyhow, my serious question is, I've read a little recent article that we published with some colleagues about having board representatives in discussion with each other. And I just, you know what I'm talking about?
Yeah.
Okay.
Thank you for reading that.
Yeah.
That article now is to read. He just read one of my papers. My mother had read it, and now Wayne's read it. That's fantastic. I love it.
Well, can you maybe describe the benefits or those discussions where people that may not have, say, a representative of a telemarketing company, telehealth company, to talk to a hospital director or clinic director? What's happening in that?
Yeah, that's a great question and a great comment. So yeah, we have a paper that was recently published in Journal of Operations Management that looked at board representation within a focal company. It doesn't matter if you have customer representatives on your board or supplier representatives on your board or both, and you know, what is the best type of scenario. And then we used what's called Tobin's Q, which is a measure of financial performance for the firm. And you know what we find, which isn't, I guess, super surprising, but it's important to have customer representatives on your board. So it's advantageous for the focal firm to, of course, better understand their customers. They can create some upstream supplier advantages as well. But you're totally right. So then you asked about, say, telemedicine. So that, you know, that is really an emerging field in healthcare, is this whole idea of collaborating with suppliers, right? I mean, if you go into store 5260, the Walmart store in West Pleasant Grove, what do you see? You see bowling teams worth of men and ladies wearing golf shirts with, you know, their company logo on them, and they're going from end cap to end cap, and they're talking about the modules, and they're collaborating. That's Walmart representatives and supplier representatives working together in a store, actually trying to improve our experience as customers, right? That largely hasn't existed outside of the OR in a hospital. You have a lot of surgical reps in the OR handling instruments and medical devices and implants and so forth to the surgeons. But in terms of actually working together, like on this or on a supply chain issue to, say, reduce inventory levels or reduce handoffs or so forth, it's just an emerging thing, just an emerging phenomenon. But one that we believe from other industries ought to be useful. Thanks. Yeah, Meredith.
My question is for Jake and Shannon. but
Great,
I think,
terrific. Come on up here.
I think it might intersect with your hair
Oh, no.
as well, because it does involve United. So I also gave birth at a birth center. And well, long story, I actually gave back to a hospital in the middle of it. I tried to get it. There were some complications. And my insurance, which was the university's insurance, UMR, said, oh yeah, no problem, we'll cover it. And then once all was said and done, they denied to cover any of the claims. This was the Northwest Arms Birth Center, which was overseen by Nicole Scally, who's still an operating OBGYN here, but birth centers no more. And I always assumed that their closure probably had something to do with one of the largest employers in the state, largest insurance company not reimbursing them. Anyways, my question is, in your interviews, did you find insurance to be one of the large barriers for the birth centers. I'm not sure how complicated the approvals are for them as it might relate to others, but did that come up a lot?
Yeah, for those who are not with us, the question was, has the impact of insurance companies affected any of this? Your answer.
Yeah, well, yes and no. So there's a lot of variation in the birth centers, right? Some of them don't take insurance at all and they're very upscale.
That'd be like a direct pay.
Yeah, exactly. But I
Okay.
mean, they're like boutique experience type of birth centers, so they're
okay.
cash only.
Yeah.
The patients can seek reimbursement from their insurer afterwards, but the birth center doesn't take it. But I think the bigger issue with insurance is the Medi-Cal, right?
Yeah, so in Washington, there's a lot more uniformity across the board because all birth centers have to be licensed. And so you can imagine that for insurance companies, they need to have a plan for how to handle that. In California, that's not the case. So you have these birth centers that can be on the far end of costs and also of experience because they are just pretty much reliant on these very affluent individuals to pay and to pay privately. On the other end, we saw with the Medi-Cal example up here that for a birth center to be able to accept Medi-Cal payments, they had to be licensed. And so a lot of it in this instance came down to sort of the ethos of the individual midwife, whether the midwife really believed that their job was to provide care to all, and whether that was like really important for them. But because of the difficulties with Medi-Cal specifically and the low reimbursement rates, and then also more generally with insurance companies, they did not have nearly as stable of a business model. They really were struggling because even though from the insurance perspective, often paying for a person to birth is less many times because you have a midwife and you don't have as many opportunities for interventions. At the same time, we found that it really was a serious struggle for these midwives to get paid because if their patient does get transferred, they don't get paid. And they get paid after all of the pre-birth care. They only can trigger that payment with the insurance company once the birth happens, or maybe even at their 6-week postpartum appointment. So they get basically one fee for that entire experience from insurance companies. And insurance companies are really significant mediator in this entire experience.
I'll just add in, yeah, totally agree, 100%. Medi-Cal must be Medicaid.
Medicaid in California.
Yeah. So the other thing about like here, Meredith, is that each state, it's very decentralized. Each state has a Department of Insurance, and each state has what they call mandates. You've probably heard of mandates. Well, so in one state, you might have mandated, this is a wild example, but you might have mandated midwife coverage. In another state, that might not be a mandate. So what that means then is when you go to a self-funded employer like the university or most large employers are, the insurance company, in this case UMR, is really just a third-party administrator. They're just a claims adjudicator. They're following the rules that the employer has put in place, and the employer selects. Now they have to select the mandates, but anything over and above the mandates is kind of at the employer's discretion. So there are multiple levels of kind of decision-making authority, if you will, in terms of whether that particular procedure is covered.
We have a question online, because I know we're just about time, and we do have audio for folks online also, but Sylvia Marino is joining us from Alice Walton School of Medicine, and she asks, did you consider the theory that self-control is a finite resource? For example, is it difficult to be on a diet and a financial diet or budget? And she said, in perhaps telemed versus in-office tap into that finite resource at different rates.
Yeah, I think that's a fantastic point. That is absolutely the logic of the arrow. No question about it. I probably didn't articulate that clear enough, but I appreciate that comment, and I'll definitely make certain that we describe that more thoroughly, more carefully in the paper. Thank you for that. It's a great point. Love to talk to you more about it.
You present Washington and California as two examples of what is kind of clear and not so clear, right? Can you just picture like what's the scenario in the state of Arkansas, like we closer to Washington, closer to California? Or it's even.
Yeah, I actually don't know. There were birth centers.
There are zero, but
Yeah.
we're in Arkansas right now.
There's zero right now.
Zero.
Yeah, I didn't think there were any. I think that has a lot to do with reimbursement rates from the Medicaid. Whatever it's called here. Yeah, so that's, I don't know about the regulatory environment for licensing it here, but.
So,
I was gonna say also, I think one thing that we do know about midwifery care and birth center care here in Arkansas is that the culture is not particularly friendly toward it. And so when we talk about that notion of cross collaboration, educating the doctors, educating the insurance companies, oftentimes actually hospitals can be very influential in terms of bodies to make decisions around this, because hospitals are the ones that are actually usually having significant cost reductions when midwives are delivering care, if they have a birth center. And so oftentimes the physician groups might be against it, but the hospital administrators are for midwifery care. So we don't have any birth centers, and we have very few practicing midwives even. And I think a lot of that, from my understanding, and I'm not an expert in Arkansas, is around that cultural notion of how much do we value what they're doing, et cetera.
just one thing to add to that, there are also policy, structural, and industry structural impediments too. One thing to look into is what's called Certificate of Need Law, CON. 32 states in the United States have a certificate of, I don't believe it, but roughly half or a little more than half have certificate of need laws for different service lines. So for example, before I got my wacky PhD, I used to run diagnostic imaging facilities. My entire business model that I created was to identify states that had certificate of need law for diagnostic capital equipment like MRIs, CTs, X-rays, well, not X-rays, but CTs, PET scanners, right? And what I would do is I would find an adjacent state. So like Michigan was certificate of need, Ohio did not have a certificate of need for MRI machines. And I would just plug in facilities right up along the border of the state, and I would draw patients out of these CON states. So that's going to influence, these different service lines as well. And there are many, many different categories, for certificate of need. Quick example, in 2000, when I was back in industry, there were 88 MRIs in the state of Ohio, state of Michigan. 88 MRIs in the state of Michigan. In the city of Toledo, just over the border, we had 30. Okay. So there clearly certificate of need influences the healthcare capacity.
Shannon, when you said about the culture and it's affected by the culture, are you referring only to the culture within the medical provider network? Or I guess how much are things influenced by the culture of the pregnant women and the communities they're coming from?
Yeah, the question was how much of the culture of the state and of the pregnant women impacts, that relationship between midwives, OBGYNs, et cetera. And I can't really fully speak to that. And even I will say, there are many, many OBGYNs who are midwife friendly, many. But I think, with declining birth rates, what we're also seeing is overall declining birth rates in the US. And so I think there is like this overarching concern or perceived threat around, well, if you get a birth, then that's taking a birth away from me and that's taking money out of my pocket. And so when I talk about culture, it's like all sort of, it's all entangled with that. But I think there's a lot of opportunity in Arkansas because we have such a rural population in much of the state. There's really an opportunity for midwives to provide care and hopefully for some of those individuals to really receive many of the benefits that come from having such a long relationship with that provider, prenatal, during birth, and postnatal.
I think just anecdotally, because my wife's a midwife and she was until recently practicing here, at least in Northwest Arkansas, there's a ton of demand for midwifery care, right? A lot of patients prefer to see a midwife because of the model of care. I think the hostility to midwives or birth centers comes from more of the power map stuff that Shannon was sharing, right? So physician groups I mean, even if the hospital itself realizes there's cost savings by having a midwifery group as opposed to a physician group, they still need the physicians, right? And so they can't upset the physicians by starting a midwifery group because then they're gonna walk to the next hospital or whatever, so it gets a little bit complicated.
Just do a follow-up, sorry, last one. So from the map that you present, right, there are a lot of components that need to play together to make it happen. If we were, for example, aiming to promote that in the state, what would you say would be the components that would be key to start having that?
They need a lobbyist.
In that,
I think David said it best, is money, right? Like the models of reimbursement for deliveries, right? Like you can change sort of the incentives. I know from my wife's experience that doctors didn't like that she was getting the low risk births, right? Those were the easy births to do. And the doctor would get paid more than my wife would to deliver those babies. I mean, unless it was a C-section or something surgical, they would get paid more, but like it's the same. They're gonna get paid same for an easy birth or a more complicated one. So, you know, if you change those financial incentives, I think that's where you really change it. Change the system.
Their power map was really, I think, an exceptional visual to demonstrate the complexity of the healthcare system. You know, healthcare, you know, for 25 years that I've been around has been plagued by high costs, increasing costs, problems around access to care, affordability is a problem, quality of care is a problem. And it's not because healthcare leaders are not smart people. That's not the reason. The reason is the complexity. You know, when you think about a mainstream industry, right, and how it's organized from a vertical perspective, right? There's a customer that pays, you know, say in our case here, a retailer, and the retailer pays the supplier, and all those financial transactions are aligned. It aligns all of our goals, right? That doesn't exist in healthcare because as a consumer, I'm paying 30% of the cost of healthcare in my premium. I'm paying 7% through the cost of copays. My employer is paying another 65 or 70% of the cost of care. So that we really, one problem, and there's several challenges in healthcare, but one key challenge is the fact that we don't enjoy the same clear financial alignment that many other industries or supply chains.
Good. One more. My question is related to equity, and it's every time I hear the term value-based care, I cringe or I'm concerned about the implications of that on equity, and your description of it and your comments about it sort of made me more concerned, or sort of fed those concerns. Is that what I think we're saying is that those facilities that have the ability to provide better care, and in the example you gave, that have the clientele with the resources to fill out those forms and respond, and have the culture to respond to the care that they're getting, are getting paid more than those that are providing care to people that may not have the resources, may not have the familiarity with, responding on an app and filling out the form to say that my care was good. And it just seems to me like we're exacerbating inequities with this notion of value-based care. And how can we, am I wrong on that, and how might we avoid that?
Well, I mean, I think that's a really interesting perspective. I certainly wouldn't say that you're wrong. I guess the counterpoint would be if you have a hospital that's providing a better experience for their patients, if the physicians are communicating better, if the nurses are communicating better, if they're managing patients' pain better, if the patients are getting their discharge instructions, right? If the patients know what to do when they leave, if their processes of care are better in that hospital, for example, you're getting an aspirin within 30 minutes of arrival for a myocardial infarction. If that hospital has fewer 30-day readmission rates, and because of that, it's a measure that they're providing better care, don't you think they should get 2% better reimbursement? I mean, I think fundamentally we reward better providers, better, anything that's better, right? When I go to the store, if I've got 2 tubes of toothpaste and one is a nickel cheaper, I'm buying the tube of toothpaste that's a nickel cheaper if they're all things are considered equal.
But I guess maybe it comes down to what Jake was saying about, you know, the difficult cases and with births. So, you know, if you're providing care to people that have the difficult cases, and maybe difficult doesn't mean that they're going to have a, you know, preterm birth or they're going to need a C-section, but if you're providing care to those people, then shouldn't you be rewarded for that? You know, and shouldn't that be a factor in assessing the outcome?
Absolutely. So what you're talking about is what's called case mix index. Case mix index for hospitals is a measure of the complexity of the patients that they serve. And there's a wonderful Harvard Business School case I'm happy to share with you. Toby Cosgrove, the former CEO of the Cleveland Clinic, had exactly your belief. That was always the belief of academic medical centers and tertiary care centers is, well, doggone it, we treat sicker patients. And because of that, you know, they're going to be less satisfied. And the way the story goes, he went to a Harvard exec ed session, right, and he left there with a kind of an eye-opening experience where he started to realize, wow, we can actually treat patients well. We can have high-quality outcomes. We can provide both technical quality as well as experiential quality, and we can do both. And it led to a really radical paradigm shift at the Cleveland Clinic. I'll just tell you, in our studies, you know, we don't see really relationships between the hospital's case mix index necessarily and their HCAHPS scores necessarily, and we can control for and parse out that variance and do our best. But I think it's a great point and one that, you know, we've got to you know, be working on and always keep top of mind, you know, as we move this thing forward, because that's today, right? Tomorrow could change. So thank you for that.
Let's thank our panel this morning. Thank you. And if you do have some time, we may have continuing conversation, but we'll go ahead and end our webinar. And thanks for being already so generous with your time this morning, going over our set stop time. But I'm sure we may have some more conversation. Thank you.
Awesome. Thanks.